Up to this point, we have talked about the different ways the body processes the drug. We'll now focus a little bit more on pharmacodynamics. Do you remember what pharmacodynamics was? Well, recall that pharmacodynamics refers to the effects the drug has upon the body. So the USMLE loves to test your knowledge on the concepts of competitive antagonism, non-competitive antagonists, and partial agonists. So by test day, you should be able to recognize all three forms. Don't be surprised if they show an unlabeled graph and expect you to determine what type of agonist or antagonist is going to be depicted. So let's break down the concept of receptor binding. We're going to start off by looking at our graph here. We have a y-axis, which is the drug effect, and our x-axis is the dose. Drawn in, we have a blue agonist here, or a drug that exerts some effect. Notice how at a certain dose of the drug, this agonist will exert a 100% maximal effect. So now we can draw in a competitive antagonist. So you can see the effect of the competitive antagonist is going to be to shift the curve to the right, which actually represents a decrease in potency with no change in efficacy. I'll say that again. We see that when we add a competitive antagonist, there will be a decrease in potency with no change in efficacy. In other words, a higher concentration of the drug is now required to achieve this given effect, but the drug can still achieve the same maximal effect. So notice here that the drug is still exerting a 100% maximal effect. However, we just need more drug to achieve that effect now. The effect of benzodiazepine, such as diazepam on the GABA A receptor in the presence of flumazenil, is going to be an example of competitive antagonism. So in this graph, diazepam is going to be our agonist, or our blue line, while our competitive antagonist is going to be flumazenil. The shift to the right will represent what flumazenil plus diazepam, or an agonist plus a competitive antagonist, looks like. So after saying all this, what do you expect is the treatment for a benzodiazepine overdose? Well, if you're thinking flumazenil, a benzodiazepine competitive antagonist, you'd be correct. Flumazenil is going to decrease the maximal effect at a given dose. Hence, it's going to be beneficial in diazepam overdose. So you'll just need to shift the curve to the right in the example of diazepam plus flumazenil. So what's a potential serious side effect of benzodiazepine withdrawal? Seizures. So you have to be careful and actually taper the flumazenil so you don't induce seizures. You don't want to just give a whole slug of flumazenil to induce a benzodiazepine withdrawal, because then you can possibly get seizures. Our next example shows the curve of a non-competitive antagonist. The curve is going to be shifted down this time. Remember our last slide we saw the curve shifted to the right? In the case of a non-competitive antagonist, our curve shall be shifted down now. And this corresponds to a decrease in the efficacy, or a decrease in the maximal effect. Increasing the agonist concentration will have no effect on the maximal effect because of the non-competitive antagonist is present. An example of this is going to be norepinephrine and phenoxybenzamine acting upon alpha receptors. Phenoxybenzamine is a non-competitive antagonist at alpha receptors, so no matter how high the concentration of norepinephrine is, its effects are going to be reduced. Therefore, this drug is good at treating hypertension in patients with a pheochromocytoma. Now, the endocrine section will cover the important points of pheochromocytomas, but I want you to remember, a pheochromocytoma is an adrenal medulla tumor of the chromaffin cells, which releases a large amount of catecholamines into the bloodstream, which then go on to stimulate the alpha receptors. So we have a large release of catecholamines, they go into the bloodstream, they're going to stimulate our alpha receptors here. Therefore, phenoxybenzamine helps antagonize the effects of a catecholamine releasing tumor. Now, a similar example would be glutamate and ketamine acting upon NMDA receptors. This third graph is going to show a partial agonist. Now, partial agonists act on the same receptor site as that full agonist would, but it has a reduced maximal effect, or a decreased efficacy is a different way to say it. Potency is going to be a different variable, and it can either be increased or it can be decreased. It can even remain unchanged. This independence of potency and efficacy is an important topic on the boards, and it's frequently tested. Now, in this plot that I have shown, we have a potency that is increased or shifted to the left, but that's not to say that it couldn't be shifted to the right or shifted down as well. A key characteristic of the drug class of partial agonists is that when partial agonists are given alone, they act to stimulate a receptor. However, when they're given in the presence of a full agonist, they're going to act to reduce the overall effect. So I'm going to say that again. When a partial agonist is given alone, it'll actually stimulate a receptor. You just won't get as big of an effect as when you would give a full agonist. Now, here's an example. We have morphine and buprenorphine. So morphine and buprenorphine act at the opioid mu receptor. When buprenorphine is given to an opioid naive person, he or she will feel this analgesic effect. However, when it's given to a heroin addict or someone who is used to a regular supply of full opioid agonists, he or she may go into a withdrawal because the receptor is only being partially stimulated. It's not being fully stimulated. Morphine would be fully stimulating the receptor. Buprenorphine is only partially stimulating the receptor. So you may actually see some withdrawal symptoms because remember that receptor is only being partially stimulated. Even when heroin, which is a full agonist, is administered, its effects will be partially blocked by this buprenorphine. Since this is such an important topic, let's make sure that you're paying attention. In pharmacodynamics, the addition of a non-competitive antagonist is going to do what to the efficacy of an agonist? Is it going to increase, decrease, or not change? So think you know it? Adding a non-competitive antagonist will decrease the efficacy of the agonist alone. It's going to shift the efficacy downwards. Remember that a non-competitive antagonist will shift the curve down or decrease the efficacy, while on the other hand we have a competitive antagonist which is going to shift our curve to the right. Non-competitives are going to shift downwards. Competitive antagonists are going to shift the curve to the right, or decrease the potency is another way to say shift to the right. Let's move on to the concept of therapeutic index. Now, the therapeutic index is a measure of a drug's safety. The therapeutic index is going to be defined by an equation, and that's going to be our TD, or toxic dose, 50%, divided by our effective dose, 50%. So the TD50 is the dose of the drug that is going to be toxic in 50% of the population. If we took 100 people, 50 people would be sick if they took this certain dose of a drug. And the effective dose 50 is going to be the dose of the drug that is effective in 50% of the population. Now this can be remembered by the memory aid TITE, which stands for therapeutic index TD over ED. So that's a simple way to remember it. Ideally, a good drug has a high therapeutic index, meaning the drug requires only a small dose to be effective, yet would require a large dose to become toxic. So that way if somebody accidentally took a double dose of their drug by mistake, it's unlikely to cause harm. So looking at the equation here, if I asked you, would you prefer a drug that has a high therapeutic index or a low therapeutic index, you would want a high therapeutic index, the safer drug of course. So let's look at this visually. We have two different graphs here. In this example right here, we have a drug with a high therapeutic index. Our top line represents our toxic dose 50, while our bottom line represents our effective dose 50. Now we would want enough drug to be in the plasma that it's above our effective dose. We would want that drug to actually be effective, yet we would want it to be low enough that we're not experiencing toxic side effects. So here we give a dose, we get a peak, and we get a trough. We get a peak because we give another dose, and we get a trough. We're above the effective threshold, but we're below the toxic threshold. This is a good drug, a high therapeutic index drug. We take a look over here where we see a low therapeutic index drug. We have to give enough drug to reach plasma concentrations that are above our effective dose. I mean, if we don't give enough drug to be effective, why even give the drug in the first place? But we have to be very careful in this situation because if we give too much drug, we can easily cross this toxic dose 50 threshold and thus get some undesirable side effects. Now please note that the therapeutic index can be modified in some animal studies. So in some animal studies we can get the lethal dose 50 replacing the toxic dose 50. So the lethal dose 50 would be where 50% of the subjects would die by taking a certain amount of a drug. Now we can take a look at therapeutic index one other way here. Now we see two curves. One is going to be the effective dose of the drug, and then the other is going to be the toxic dose of the drug. Now notice at this point right here, when we have a drug concentration that is very low, we're going to see that nobody is really experiencing the effectiveness of the drug. They're not going to get any effects from the drug. However, as we give more and more drug concentration, when we reach about here, we see that 50% of the people who are taking this amount of the drug are receiving some sort of beneficial side effect. So they're receiving the therapeutic effect of the drug. As we give more and more drug, now we start to shift curves. We start seeing people who are experiencing toxic side effects of this drug. And at this point right here, when we give this much drug concentration, we see about 50% of the people experiencing toxic side effects. Now we can compare these two curves. We can tie in our concept of therapeutic index. Remember, our formula was toxic dose 50 over ED 50. So the therapeutic index is actually going to be the area where the arrow spans right here, from our 50% ED to our 50% TD. So the therapeutic index is a comparison of the 50% from the toxic dose to the effective dose. So let's now test our knowledge with a flash quiz. A new cholesterol-reducing drug is currently undergoing clinical trials to determine its safety. Test subjects are told to take different doses of the drug for 4 weeks, and then the data will be collected. The trial shows that at a dose of 10 milligrams, half of the individuals taking the drug show an improvement in cholesterol levels. At a dose of 100 milligrams, half of the individuals taking the new drug develop some severe hepatitis. Now, what is the calculated therapeutic index for this drug? Think you know it? Alright, so the answer is going to be a therapeutic index of 10. So the question is asking for a simple calculation of the therapeutic index. The equation for therapeutic index, do you remember what that was? It was toxic dose 50 divided by effective dose 50. So there's our equation for our therapeutic index. Research shows that this new drug is effective at 10 milligrams. It's going to be effective at 10 milligrams in 50% of the individuals, which is what was in the question stem. So the ED50 is going to be our 10 milligrams. Now the toxic dose, 50%, was 100 milligrams. 50% of the people who took 100 milligrams developed that severe hepatitis, so that will be our toxic dose, 50%. So plugging this into our equation, it's really just simple math. 100 divided by 10 is going to be a calculated therapeutic index of 10. There we go. Let's now take a break from pharmacology review and actually transition into a few practice USMLE style questions. A 43-year-old man with a long history of chronic renal insufficiency comes into your emergency department with a 5-day history of a productive cough and shortness of breath. Physical exam reveals rales in the middle lobe of his right lung, and X-ray of the chest shows consolidation in that same area. He begins therapy with levofloxacin. Now, which of the following indicates how the dosing of the levofloxacin would differ in this patient as compared with a patient with no underlying health problems? So here are all your options, and I'll let you read through them and think about it for a few seconds. Okay, hopefully you have an idea by now, so let's go ahead and see what the answer is. If you chose F, the same loading dose, but a lower maintenance dose, you'd be correct. In patients with impaired renal or hepatic function, the loading dose should remain the same as a healthy person. This is because the formula for the loading dose, let's clear some space off here. Do you know what the loading dose formula was? Yeah, loading dose is equal to our target plasma concentration times our volume of distribution divided by our bioavailability. So you see, nowhere here is there anything about the clearance of the drug. So if a patient has impaired clearance, it really doesn't matter. It's not going to affect the loading dose. However, do you remember what our maintenance dose formula was? Well, the maintenance dose is equal to our target plasma concentration times our clearance of a drug times the dosing interval divided by our bioavailability. So notice here that there is clearance in the question. So in someone who has impaired renal clearance, such as with chronic renal insufficiency, there is going to be a factor that we need to take into account. The kidney or liver disease is going to affect the clearance. So with the maintenance dose, we'll need to dial it down a little bit because of the toxicity or the side effect concerns. This is an important concept to remember on the USMLE because they love to ask questions regarding the loading dose and the maintenance dose. Sometimes they'll ask you to calculate a dose, and sometimes they'll just ask you conceptual questions like this one. Let's do one more question. A 43-year-old woman presents to the emergency department following a motor vehicle collision. She sustains no serious physical injuries, but she appears drowsy and states that she is feeling very sleepy. Emergency staff collected several open medication bottles from the floor of her car. Although the contents of these two bottles cannot be determined, the patient's recently filled bottle of diazepam, which is a benzodiazepine, is almost empty. The patient quickly becomes unresponsive and stops breathing. Now here's the question. What is the mechanism of action of the agent that'll actually reverse her symptoms? And I'll give you a few seconds to read through the answers again. If you're struggling, here's your hint. Thinking back, we've already covered the concept of agonist-antagonist relationship of a benzodiazepine. Okay, so you're ready for the answer? Hopefully you said C, competitive inhibitor of the gamma aminobutyric acid receptors, which can be written shorthand as GABA A receptors. My A's don't want to stay there. So it could be the GABA A receptors. Recall that flumazenil is going to be used to treat a benzodiazepine overdose. There you go, flumazenil. Now the benzodiazepine in this case, which is our diazepam, is going to be our agonist, while our flumazenil is going to be our competitive inhibitor. We've already talked about that. So do you remember what the characteristics of a competitive inhibitor are? Competitive inhibitors resemble the substrate and actually bind to the active site of the enzyme. So thus, on a Lineweaver-Burke plot, remember our double reciprocal plot, competitive inhibitors are going to increase the Km. So the x-intercept is actually going to be shifted to the right, meaning they have a decrease in the potency and affinity. On the other hand, competitive inhibitors do not alter the Vmax at all, so the y-intercept are going to be unchanged compared to the uninhibited graph on that Lineweaver-Burke plot. So these practice questions are about the length of a typical USMLE style question. They should take you approximately 30 to 40 seconds to read over and look at the answer options, then give you a little bit more time to think through what the answers are. In this example, you can get rid of options 1 and 2 immediately because an agonist would not reverse the effects of diazepam. Only a partial agonist would diminish the effects, but not actually reverse the effects like the question is asking. So next, I briefly touched upon the fact that benzodiazepines, such as diazepam, act on the GABA A receptor. I like these questions because they test a little bit of memorized material, but also force you to apply this concept that we've talked about to the question as well. Now, I took these questions off the USMLE RX QMax question bank, which has quite a few questions that you may see again on test day. My biggest recommendation is doing as many practice questions as possible, and taking actually the time to understand why you got the question right or wrong. Are you ready for the next section in pharmacology? Alright, let's do it.